very much for joining us today. My name's Rachel. I'm the health educator here at the Epilepsy Foundation of Northeastern New York. Before I do an intro, we're going to do just a little bit of housekeeping. If everybody could mute themselves and stay on mute for the duration of this presentation, that would be fantastic. If you have any questions throughout this presentation, please feel free to put them in the chat. We will be addressing questions at the end of this session. So they will be getting addressed at the end rather than throughout the training. If I understand, this is absolutely everybody's lunchtime, so if you are eating or something like that, you absolutely can stay off camera if you prefer to do so. We welcome everybody's beautiful faces on camera as well, but if you have some other things going on, I definitely understand that as well. So definitely make yourself familiar with the chat. Please feel free to ask any question, which again will be addressed at the end. We also will be recording this lecture and putting it on YouTube probably by the end of this week for anybody to kind of go back and review any of the things that you might have missed as well. So do be mindful of that as well for the recording. Just to get started, again, thank you all very much for being here today with the Epilepsy Foundation of Northeastern New York. We're very excited to partner with our doctors today for this neuropsychological evaluation and epilepsy talk to discuss some of the important features and kind of demystify what this all means. This will be presented by Dr. Christina Wong, who's an adult neuropsychologist at Westchester Medical Center, and Dr. Patricia May, who is a pediatric neuropsychologist at Boston Children's. So we are very excited to have both of you here today, sharing your knowledge and answering your questions, our audience's questions as well. So I will hand it over to both of you. Again, thank you very much.
Thank you, Rachel. All right, let me see. So we have nothing to disclose. And today we're going to be talking about what is neuropsychology. Most people often tell me that they never have heard of neuropsychology before. So we're just going to give an overview of what is neuropsychology, who are neuropsychologists, what might be involved in a neuropsychological evaluation if you're ever referred for one. And we'll talk about why someone who has epilepsy might be referred for this type of evaluation. And we'll also cover what recommendations sometimes come from a neuropsych evaluation and how it can help with treatment planning and other supports. So just to start, so clinical psychology is a branch of psychology that focuses on the diagnosis, assessment, and treatment of mental health issues. Neuropsychology is a subspecialty within clinical psychology, and it focuses on studying the relationship between the brain and behavior. It explores how the brain's structures and the biological processes relate to cognitive, behavioral, and emotional functioning. And so we do assessments that involve specialized evaluations to help learn how well someone's brain is working. So in the US, neuropsychologists have a doctorate degree in clinical psychology, and they have specialized training in neuropsychology. And so they'll have a degree like a PhD or a PsyD if you're looking at different providers. And neuropsychologists will focus more on the assessment and diagnosis of cognitive disorders, but some neuropsychologists will also provide therapy or intervention. And if a neuropsychologist is practicing clinically, they'll be a licensed psychologist. And so neuropsychologists serve a lot of different populations from all different age groups and individuals with many different types of conditions. Okay, so what exactly does neuropsychology measure? An assessment will help provide an in-depth understanding of a patient's current cognitive, behavioral, and emotional functioning. And this information can help aid in determining a diagnosis It can help understand the cause of someone's cognitive changes that they might be noticing. It can help serve as a baseline, and then repeat or follow-up evaluations can be done to help track cognitive changes over time, or to see if there are any changes after some type of treatment. Sometimes someone may have an injury or other insult to the brain, and a neuropsych evaluation can help with determining the degree of impairment that someone might be experiencing. It also helps characterize cognitive strengths, so areas that someone's doing well in. And that can be really helpful too when we're making treatment recommendations, because we can help think about what are someone's cognitive strengths that might help them compensate for an area of difficulty. And so we use these types of evaluations to help identify patients' treatment needs and assist a medical team with treatment planning. And there are a couple of different parts of a neuropsych assessment. One part includes a clinical interview, and this will involve the examiner or neuropsychologist speaking with the patient, and usually we have family members there as well to provide their input on what they're observing about their loved one. We discuss the course of their cognitive concerns, like how long they've been noticing some memory difficulties or attention problems. And we go over their history and different background factors that can also contribute to how they're doing cognitively, and just help us understand how the patient is functioning at different points. Our assessments include a medical record review based on what's available to us. And then a large part of the assessment, kind of the long part of the assessment, is that we administer cognitive tests. So these are often administered by the neuropsychologist, or sometimes we'll have a trained neuropsychology technician or psychometrist who does the test administration part. These are often paper and pencil and out loud tests. And I'll go through specifically what are some of the different areas that we look at. Some tests are sometimes on a computer or a tablet, and we often have patients complete self-report questionnaires to collect more information about things like their mood, anxiety, and other factors too. Okay. So what kinds of cognitive skills are assessed when we do a neuropsych assessment? So sometimes a lot of how we decide what to assess and what's included in the testing depends on the referral question. So why is this person being referred? So for some purposes, we may do full IQ testing. Other times, there may just be some select tests from an IQ measure. Sometimes we'll take a look at academic functioning. We look at someone's attention abilities. We look at how quickly they can process information using different time tests. One of the most common areas that patients report concerns in is related to memory, and that's often a big part of our assessments too. And we will take a look at how someone learns and remembers both verbal and visual information. And we look at different aspects of memory that can be affected. So one part of being able to remember something is affected by how well do you actually take in and learn new information. So we do some assessment of learning ability or acquisition of information. How well can someone freely recall information on their own? And we usually look at that after a delay period. So did they store that information and can they retrieve it? And then we also do some recognition testing. So kind of a little bit easier than recall, we help look at, can someone accurately identify whether they heard or saw some information before? A neuropsych assessment will look at language skills, so how well someone is able to comprehend information. We'll look at how well we look at what we call verbal fluency, how well they can generate information. And we test things like their ability to retrieve words when they're shown a picture of something, and so we'll call that naming ability. We look at visual spatial skills in different ways. So this might involve having to construct something using blocks, or to draw something or copy a picture. And another area that we assess is called executive functioning. So these are kind of our higher order thinking skills. They tend to be related to the functioning of the frontal lobe, and it has to do with things like being able to inhibit your behavior, so not do something when you're not supposed to. Being able to, we call it set switching or shifting, so being able to move your attention between different things and keep track of where you are, monitor your performance. How well can you problem solve? And we look at things like reasoning in this area as well. Testing may include fine motor abilities and sensory abilities. So different parts of the brain relate to motor function. And another big part, again, of our assessment, we know that mood, depression, anxiety, these things can affect how well our memory and attention work. So we always are including assessments of emotional functioning. Sometimes pain or sleep are factors that can also interfere with cognition. So we may administer some measures that help us collect data on that as well. And another important part of our assessment is looking at how well someone functions in their day-to-day life. Are they independent? Are they able to take care of some pretty complex activities? Have their memory and thinking difficulties started affecting some daily activities? Are they having to use more compensatory strategies, or do they need assistance from someone else to help manage certain things like managing their finances or their medications? So we take a look at those abilities too. And I'll say too that, it seems like a lot of different areas to assess, but we really want to get a full comprehensive picture of someone's cognitive function or how well their brain is working in a lot of different areas. So even if someone says, it's just my memory that seems to be, that I'm having difficulty with, we still assess these different domains so that we're able to say, these areas are the ones that are intact. These are the areas where we're seeing some more weaknesses or difficulties, because sometimes someone might also not be aware of certain cognitive changes that they're having. So we want to be very thorough with our assessment. Okay. So these tests that we give are very standardized. So they have a specific set of instructions. They have items that are selected and that we use with each patient for certain tests. This allows us to then compare our individual patients' performance on these measures to other people who are in a similar age group. Sometimes we're able to adjust for other factors that might affect performance, like level of education. And then we're able to say, when this person's given this test in the same way other people have been given this test, their memory is functioning within a normal range or within the expected range. Or maybe they didn't remember as many words as other people in their age group. And what we'd be able to, describe that as a particular area of weakness. And then we're thinking about what could be contributing to that difficulty. So if you ever have an assessment, you may see that we're using things like percentiles, so kind of 50th percentiles, right in the average range. And then we're looking at, which abilities are falling within an average range, any strengths above average, or any areas of difficulty falling more below average or exceptionally low performances. So we'll be talking a bit more about epilepsy and seizures and how they're related to thinking abilities and cognition. But we also, as part of our evaluation, we're thinking about what are other things that might contribute to cognitive difficulties. So things like having an infection, history of head injuries, has this patient had a stroke, alcohol use, sleep issues. These are all things that we're taking into consideration when we're kind of trying to figure out what are those causes of someone's cognitive concerns. Sometimes there are things that are reversible, like vitamin deficiencies, thyroid conditions. We consider medication side effects, as well as stress and psychiatric concerns like depression. So as part of our evaluation, after we do all this data collection in terms of talking to the patient, talking to their family, reviewing their medical records, and doing the standardized testing, we put all of that together to help form our case conceptualization and come to a diagnosis. So we'll go through a little bit more about what that might look like within the assessment of someone who has epilepsy. So there are, again, a lot of different factors that we need to take into consideration. So there are things related to the location of seizures, how old was someone when they started having seizures, and then again, those other factors that could be changed or are more modifiable factors, like their medications, how well are their seizures controlled? Are there difficulties related to their mood or motivation that might be affecting how their thinking abilities are doing? And so an epilepsy workup can consist of several different steps and tests. So typically we're using EEG, or the neurologist will be having the patient get an EEG. Neuroimaging, such as an MRI or CT scan, might be ordered to look at the structure of the brain. Other tests can help look at neuroimaging tests can look more at the function of the brain, like PET scans. Sometimes genetic testing will be ordered if it's thought that someone's seizures might be related to certain conditions. And then neuropsych testing can be part of this workup as well to help determine how well someone's brain is functioning, and if they are having seizures in a certain area of the brain, are we seeing that in terms of how their brain is functioning as well on these neuropsych tests. So we also want to consider how are seizures being managed. So the first line of treatment is medication or anti-epileptic drugs, or we also call them anti-seizure medications. And this can be effective for a lot of patients. But for some patients whose seizures are not controlled by medications, they may be considered for something like an epilepsy surgery. And there are different surgeries like a resection versus an ablation, or there are certain devices or neuromodulation devices that a patient might be considered for. And when someone's being considered for an epilepsy surgery, neuropsych testing is typically recommended and included as part of that pre-surgical workup. And other treatments may include dietary therapy. So in general, individuals who have epilepsy have some increased risk for having some cognitive difficulties. And that's not to say that everyone will have cognitive difficulties, but that there are certain things related to having seizures and epilepsy that can increase that risk. And so the types of cognitive deficits someone might experience may depend on several factors. It could be related to the type of epilepsy or the underlying cause of the epilepsy, the location of the seizures in the brain, because different parts of the brain are responsible for different types of cognitive functioning. We also consider, or the risk of having cognitive difficulties is related to frequency of seizures. So having more seizures increases risk. Having a history of status epilepticus, or having seizures that are longer than 5 minutes, that don't stop on their own easily, and interictal activity also. So that's kind of having some abnormal brainwave activity that can be detected on EEGs in between seizures. And so an example is, so some people will have temporal lobe epilepsy where their seizures are starting in the temporal lobe of their brain. And they may be more likely to have difficulties with word finding and memory because our temporal lobes are responsible for some language and memory abilities. In frontal lobe epilepsy, we may see more difficulties with that area I described as executive functioning. So those higher order thinking abilities, being able to inhibit behavior, being able to reason or problem solve easily, think flexibly. And frontal lobe, frontal lobe is particularly important for emotional control. So we may see some difficulties or changes there, and motor functioning. So the postictal state is the term used for when people, the period of time after someone has a seizure. A lot of patients will report feeling that they have reduced cognitive function after a seizure. Sometimes this lasts for just several minutes, or for some patients, they report feeling like this can last for several days. And again, we have to think about too how the actual cause of the epilepsy might be contributing to cognitive changes. So for some individuals, like adults, stroke is a common cause of epilepsy or a head injury. And so we were thinking about where was that stroke, or what area of the brain did that head injury affect, and how might that be contributing to someone's cognitive changes. We also see in our research that a higher number of anti-seizure medications, or being on a higher dose of anti-seizure medications, can be related to increased risk of having cognitive side effects. Not every medication has a chance of having or a higher risk of cognitive side effects, but there are certain medications that may be more likely to come with that side effect. And so thinking about epilepsy and mood, so individuals with epilepsy compared to the general population without epilepsy tend to also have an increased risk for developing mood and anxiety disorders. It's possible that there are some underlying brain structures and processes that may increase risk for epilepsy and may increase risk also for having a comorbid mood disorder. Unfortunately, there's still stigma associated with epilepsy, and groups like the Epilepsy Foundation are doing a lot of good work to help reduce that. But feeling like that other people don't understand what epilepsy is, or feeling like there are some negative associations with that, can contribute to having that increased risk of having developing mood or anxiety disorders. We're often thinking too about increased anxiety related to when am I going to have my next seizure, and stress that can come with that too. There actually are some of the anti-seizure medications that can be helpful with mood. So they treat seizures, but they also tend to have a benefit for emotional functioning too, which is helpful. And it's definitely something, if someone's experiencing symptoms like increased sadness, hopelessness, increased anxiety or worry, these are things that it's definitely worth bringing up to your provider, your medical provider, because there can be a lot of benefits of treatment. So treatments that treat depression, anxiety outside of, just in general, also tend to be quite effective for mood changes among people who have epilepsy. And so this is a list of some common causes of adult onset seizures, and most of these on their own can be related to cognitive changes even without seizures being present as well. So we talked about stroke, which is one of the most common causes. Seizures will often occur within 24 hours of having a stroke, but they can also develop months later, even after the stroke or after a head injury. Other things can be seizures may occur when someone has an infection that affects their brain. If someone has a brain tumor, sometimes they'll have seizures related to that. Or when someone has a neurodegenerative condition like Alzheimer's disease, they may also be at increased risk of having seizures. But a lot of the time, the cause of the seizures is unknown in about half of people who have epilepsy. It's the specific cause of the seizures is not identified. Okay. And we're going to switch over to talking about childhood seizures. So you're muted still.
Thank you. Similarly to adults and childhood epilepsy or reason for seizures, there's a range of it, ranging from genetic causes through brain injury, whether it is traumatic brain injury or a stroke, like Dr. Wong mentioned, inflammation of the brain. But for many children, the cause is unknown. And similarly to adults, the percentage ranges somewhere from 25 to 40%, where we don't know why seizures occur. In children, most common reasons for seizures for epilepsy are malformations of cortical development and low-grade brain tumors. Malformations of cortical development are when the brain is developing prenatally, something takes a different path and develops differently, and that part of the brain may look differently. It may be organized differently, and that might be a cause of seizures. That malformations of cortical development, along with the other possible reasons for having seizures, dictate or are likely related to how seizures manifest. And there are many reasons for seizures, and there are different ways seizures can look. For some, it is a full body shaking. For others, it is kind of a freezing, almost like a statue, where individual is dazing off, and nobody can kind of shake them out of this. There are also seizures that have auras that is an indication that a seizure is coming on. Whether it is a smell or a feeling in the stomach, in the throat, a certain smell or voices, all of that might be part of the seizure. And again, all of that will be related to which part of the brain, where in the brain the seizure starts, what is the network, which parts of the brain are involved. Will kind of dictate how it will look like. And similarly, on the next slide, there are similarly, because there are different reasons for having seizures and how seizures look like. Seizures, epilepsy, are a condition of the brain, and brain, like any other organ in our body, has a role. And Dr. Wong explained and took us through all the different domains of the brain's job, what the different domains of brain's job are, like thinking and reasoning and learning and movement, and speech, and how we feel, our emotions. This is all modulated, regulated by the brain. So when there is a condition that affects the brain, it simultaneously affects these behaviors, these skills that the brain is responsible for. And for many individuals, the way epilepsy seizures affect our cognitive skills, it may be more descriptive in a way where all of us, whether we have a medical condition or not, we have areas of strength and areas of weakness. Just naturally, let's say math is a strength, or visual abilities, like seeing how things go together and being artistically inclined. It just comes without any effort. And other areas are way more challenging, whether it's writing an essay, reading a book. It doesn't have to be anything debilitating or preventing us from doing anything, but it might be just like a general area of challenge. And that will be the case for many individuals with epilepsy. For others, the cluster of difficulties that individuals may have might have a name. They co-occur together, and they have a name. And many of you might be familiar with attention deficit hyperactivity disorder, or autism spectrum disorder, intellectual disability, as well as any learning concerns, such as specific disability in learning math or reading, like dyslexia. So these co-occur quite often with epilepsy, and they're recognized as its own entity where we can, we know what the target treatments are, we know how to help, we know how to support, it has a name, everyone kind of speaks the same language. So we can act really well as a team in providing supports. And for, sorry, I just wanted to mention quickly on the previous slide, it's very psychiatric comorbidities, and comorbidities mean that the condition co-occurs with epilepsy. They're quite common, and whether it is part of the epilepsy, part of the brain development process, or whether it develops as a result of epilepsy, we quite don't know, and likely it's bidirectional. But depression, anxiety, and experiencing low self-esteem and stigma, all of that occur quite frequently, and we take it very seriously and take great care in connecting individuals to mental health supports. So when do we recognize neuropsychological assessment is important? We know difficulties co-occur, cognitive difficulties co-occur with epilepsy. So when do we think it is appropriate, it's a good time for an individual to receive this assessment? At the start of epilepsy, it's a good standard practice to seek out a neuropsychological evaluation. Other times is whenever one sees differences, changes in their functioning, that they're forgetting things, it's more difficult to pay attention. Maybe there are difficulties with balancing their finances, or difficulties in school for children. All of these kind of signal, let's connect with a professional and see whether that's something to be concerned about, something to address, or something to monitor. For changes or differences also include neurodevelopmental delay. So when you see that your child is not meeting expected developmental milestones, that's certainly a time to seek out a neuropsychological evaluation, or if there are behavioral difficulties, or whether there is a time where they were able to read, communicate, speak, and suddenly there is a regression in skill, and that skill is lost. That's also a time to seek out an evaluation. For children, a lot of times with neurodevelopmental delays, children are referred to early intervention, or school special education committee will evaluate children. These evaluations are great and will connect families and children to wonderful supports, but individuals conducting these assessments are not neuropsychologists, meaning their point of view and their lens of thinking and understanding child's development is not comprehensive to the level that neuropsychology assessment may provide. And for children, because the evaluations start much earlier, and because development is acquisition of skills, we want to support children to reach their maximum potential. It's very important to track and make sure that children stay and continue to meet expectations. And if they don't, how can we support, or how can we compensate for whatever it is that they cannot quite reach yet? In adults and young adults and older adults, supports or evaluation focus on any accommodations or services that they may need in college, in trade school, or at work with general independent living, managing finances, showing up to work on time, what difficulties are showing up that weren't there before, that we want to help address and understand and help address properly. And again, there might be many different reasons for this. It might be mood, it might be attention, it might be memory. And a lot of times, it's like a headache. You have a headache. There are many different reasons why you may have a headache. You may have migraines. It might be just a headache because you're dehydrated, or it might be a brain tumor. Similarly, we see a behavior where individuals arriving late to school, right? There are many reasons why it might be happening. So our job is to understand what is contributing to that difficulty so that we can help support and provide appropriate recommendation to cope and to help alleviate that difficulty. For some individuals, neuropsychological assessment becomes part of a medical workup for epilepsy surgery. As Dr. Wong mentioned, if the medical team decides to explore a surgery as treatment, neuropsychology will be very much involved to help understand functioning before the surgery, will help determine whether surgery is an appropriate intervention, will help understand functioning after surgery if one is completed, and then most holistically kind of be part of the team and partner with the family to go through this process, to understand what is happening and how best to support with any difficulties that might be coming up along with this process. It's not an intervention for everyone. There has to be a locus that can be alleviated with if it's a resection. For others, as Dr. Wong mentioned, there are certain devices that might be implanted in the brain or connected to brain functioning. So in all these instances, we may be involved to partner with the family. I wanted to demystify. I hope we are so far doing a good job in demystifying the neuropsychological assessment, but then many of you may be left wondering, well, what is a psychological or psychoeducational assessment? And I think the main difference to remember is that the neuropsychological evaluation is a truly holistic approach to understanding this brain behavior relationship. We look at the brain functioning as a whole with all the cognitive processes that Dr. Wong went through, which is intelligence and attention and memory and our ability to problem solve, as well as our emotional functioning. We look at all of that in the context of a medical condition or many other factors that might be contributing to this. This is our specialty. This is different from psychoeducational assessment, where the goal of the assessment is not to thoroughly understand an individual. It is to assess their general intellectual functioning, general psychological functioning, meaning are there any depressive symptoms, anxiety symptoms that might be affecting any of these factors? Are they affecting their academic performance? So that evaluation will focus on academic achievement, meaning reading, writing, math, and an IQ. Typically, any other assessment of memory or attention is not included. And the goal for school is to focus on for the student to access the curriculum, for them to learn within the school setting. And that's kind of typically where they draw their line. They're responsible for their academic achievement. With psychological assessment, that's an assessment wherever there are psychological concerns such as anxiety and depression. A lot of times IQ tests might be given just to understand whether individual has the cognitive skills that are with which they're able to access typical therapies. And if not, then it informs providers about how to tailor their approach so that it is accessible to the individual. For families and children, how do we secure supports in the school? Varies and can range from an informal plan where teacher, principal, family, student all kind of informally agree without any binding document that the student obviously needs support, and therefore we are going to allow them to sit closer to the instructor. Maybe we will give them extra time on tests and on assignments, and we'll be a little bit more forgiving in other ways. It ranged from this informal agreement to a legally binding agreement document. One of them is 504 plan and the other one is IEP. So a 504 plan, it's a legal document, it's a binding document where it ensures that individuals with disabilities are not discriminated against and they receive access to the curriculum. They have equal access to the curriculum. So with the 504 plan, it's a shorter document, but it's a document that the schools obey by and provide services for children to limit those barriers. So the child receives general curriculum that is offered to other students, but any barriers should be removed. For instance, a child with ADHD or has difficulties remembering their textbooks or needs extra time, those supports might be part of the 504 plan. So the student will be sitting close to the instructor so that it's easier for them to maintain their attention. They're going to receive extra time on tests because they may be totally distracted and need redirection, and that redirection takes time. Or they may need an extra set of books because they forget to bring them to school. On the other hand, an IEP is an individualized education program. And as the name suggests, it is a program. It's something very official and it is individualized. So it is not a blank set of accommodations. It is a individualized, tailored set of services that the school district is obligated to follow. It was agreed with the school district and the family. These are the services that the child will be receiving based on the needs that they have. So this takes a step further where it is no longer general education setting. It is my child needs special instruction. My child needs additional services that are beyond general curriculum. So it is kind of the student is taught differently in a way. It might be a different classroom where there are two teachers, a general education teacher and a special education teacher. It may mean that they are receiving related services like occupational therapy, physical therapy, speech and language therapy, counseling. This document is reviewed every year, and then children are reevaluated every 3 years. So the schools conduct their own evaluation every 3 years. A lot of times, neuropsychological evaluation will be enough, and they will take that in lieu of their own. Sometimes they will just go through their own testing, and sometimes they may supplement with what we did with their own set of measures. So in order to begin the the service to make children available for special education services, it should be done in writing because it starts the clock. Otherwise, it's very easy to not have it addressed or for it to take a long time. So to a principal or assistant principal, submit it in writing that you are requesting a evaluation to consider your child for special education services. As I mentioned, they may accept our evaluation, they may do their own. The bottom line is that there needs to be an impact on academic progress. So the school focuses on how is the child doing in school. And a lot of times, if the grades are good and child is behaving well in school, socially, and so on, those services may not be granted. There needs to be a visible impact on grades, essentially. In addition to school services, what I wanted to make sure I highlight, it's very important for some individuals to receive rehabilitation services in a community like a medical rehabilitation center, to receive executive functioning skills training or speech and language therapy or physical therapy. And that is because school services are wonderful and they focus on academic achievement and social and kind of participation in the classroom. They don't go beyond making sure that the child is able to access the community, or their behavior in community, or living independently, being a part of the community outside of school. For them, the community is the school. So that's why it's very important to have that in mind, that the school services are not all and nothing else. How are our findings used? These are, in medical settings, there's a whole list of ways how our services can be helpful. And you can read through this, and Dr. Wong covered a lot of it already. But I think what I wanted to highlight is, above all, I think what we provide is a insight into your own abilities, into your own functioning, into your own strengths and weaknesses that explain the difficulties you may have. And by doing that, it is empowering. It also guides what you may need in the future, in school or at work, or in the community. And it helps advocate for that. So our reports are also a document. It's a document that one can use to advocate for oneself, whether it is a child in school or an adult at work. In the community settings, as we already discussed, there are many services and many services and interventions that can and will be a lot of times recommended following an assessment. All of them are tailored to the needs of the patient. It may range from psychotherapeutic interventions. So we don't provide psychotherapy. We will refer to individuals who specialize in that, because it's just like neuropsychology. Psychotherapy is its own very specialized field. And then there will be other community services we may refer to support with finances or driving or cooking, any work-related recommendations that we think might be helpful. We will really try to connect the family, the individual, the patient, with any resources we may know of, including the Epilepsy Foundation. So how does the assessment look like specifically? Dr. Wong already touched upon it, but in terms of kind of timeline and imagining the day, it's a long day for children. we always say bring lunch or plan to go out and get lunch somewhere. Plan to be here from 9 to 3. It's an all-day event. We started with an interview. We perform the testing where we administer the standardized measures. We break for lunch, and then we continue with the testing. We meet for a feedback session where we discuss the results, all the information that we've gathered from the interview, from the chart with you, from talking to your doctor, from any documents from the school. We put it all together to understand how is the patient functioning now, what might be the reasons for it, and generate best recommendations. And the report is shared shortly after. Similarly for adults, the day begins with an interview and is follow up with testing. As you see, the day is shorter for adults. It's because the measures for children take longer and a lot of times include academic assessment, which is typically not the part of assessment for adults. Similarly, we meet with patients 3 weeks later to discuss the findings and provide a comprehensive report with the results and tailored recommendations. What we may recommend, we've covered a lot of that already. We may also recommend a medical follow-up if we think it might be helpful. Patient has an appointment scheduled with neurology in 6 months, but given our findings and given what the patient is reporting, we may suggest to see the provider sooner. We would recommend any of the life supports we mentioned, maybe connecting to social work as well. We may recommend psychotherapy or counseling, cognitive supports. There are therapies that focus on development of cognitive skills. So how do I train my attention? How can I train my memory so that I don't have these difficulties at work or in school? And specifically, we wanted to highlight the Hopscotch Institute or the program from the Institute for Cognitive Health and Wellbeing at Dartmouth that is a telehealth service where individuals learn how to improve their attention and memory skills. There are not many tailored services like that, so we definitely wanted to make sure we share this information with you. It might be something to look into. It might be appropriate for many patients. And to wrap up our presentation, some misconceptions about the assessment because there is psychology in our name. It makes the association with therapy. It's not therapy, although it's certainly an intervention. We really try to understand the difficulties and we do assess mood and worries. And if there is a need for psychotherapy, we'll certainly refer out for that. We are not medical providers, so we do not prescribe medication. We don't discuss medication in great detail. It's outside the scope of our expertise. And to leave with a general summary of what we've covered, what neuropsychological evaluation is, it's a comprehensive assessment of our cognitive, emotional, and behavioral functioning. So how do we think? How do we learn? How do we perceive things? How do we feel? And how do we act in a variety of situations? And it can, the evaluation can help in a variety of ways, and it's used in a variety of, we partner with a lot of providers across many different specialties. So not only epilepsy, it creates a baseline and a measure of improvement or decline when we are thinking about these serial evaluations. We can really help track how well individuals doing, whether their complaints of memory are visible on the assessment or whether it is just a subjective kind of perception of my memory is worse. Maybe it's attention. Maybe it's something else that is wrong, feels a certain way. So we can definitely get clarity around what is the reason for it. Sometimes we may not, and sometimes we may say, we don't know, but we think it's this, and let's monitor, let's do this and see how you're doing in a year or two or so. And it may help with accurate diagnosis and treatment planning, so we can help doctors understand how the cognitive functioning is involved or is part of the presentation in epilepsy and seizures, and that can, together as a team with patients and families, we will plan the treatment together. And we wanted to thank you so much for giving us the opportunity to speak with you today, and would love to hear your questions and thoughts.
Thank you both so much for that extremely informative session. It's looking like we are getting quite a few questions in the chat. The first being, how hard is it to get insurance approval?
For individuals with diagnosed with epilepsy or any medical neurodevelopmental conditions, it's not difficult.
I'll just note too, it depends on the insurance. And so even for myself, being at Westchester Medical Center, I'm somehow not in network for every insurance plan that's accepted by the physicians here based on what they were able to work out with like contracts with insurance companies. So it's always important to see, is this evaluation within the network for my insurance? And then if you're seeing someone in the community, if they're a private practice, they may have a specific panel of insurances that they work with.
All right, great. And kind of piggybacking off of that, do we need a referral from a medical provider to request a neuropsych eval?
It depends on the place. So at Westchester Medical Center, my referrals all come from the neurologist. So in order for someone to come to see me at Westchester Medical Center, they would see a neurologist first, and then the neurologist helps determine if they think neuropsych assessment will be helpful, and they make the referral. But in a lot of other situations and cases, someone can contact a neuropsychologist and schedule with them directly. I will say about the insurance question as well, that there are other options to possibly get, financial support from different institutions for certain things. And then there are a lot of graduate programs throughout New York that are clinical psychology programs that have a neuropsych focus. So they have students who are training, and they have neuropsychology supervisors who are working very closely with them. And that's a good way to get a low-cost neuropsychological evaluation, where yes, it's a student or a trainee who's working with you, but again, they're getting that close supervision for the assessment.
Really great, thank you. And I will be sending a follow-up email to everybody, but is it possible for me to share your slides with them as well?
Sure, we can provide a copy that could be shared.
Beautiful, awesome. And I will be uploading it to YouTube as well. All right, next for questions, what kind of battery assessments do you usually use when you have evaluation for adults, for example, for attention?
Yeah, so again, even if someone came in and said they're just having attention problems, we're still going to assess many of those different cognitive domains I discussed to also just clarify, is that attention difficulty really isolated, or are there any other areas that might be causing some problems? Sometimes it's more kind of brief tests of attention. So how long can they sustain their attention to take in auditory information and provide a response? Sometimes we're using visual measures to see how well can they detect errors on something that is pretty subtle. There are some sustained tests of attention that take several minutes to complete, and we're also looking at how quickly can they do that, sustain attention, how accurate are they able to perform on a test like that. And so there may be other tests too that Dr. Pethme can describe for attention, because a lot of them overlap with the same tests that are used for children.
They do. Yeah.
Well, awesome. Next for questions.
I will say too, sometimes this comes up that there may be a question of ADHD when we're thinking about attention. And so ADHD isn't something that you need to have a neuropsych assessment in order to get that diagnosed. That's more based on symptoms of attention or hyperactivity. There's, different ways to describe the symptoms that may occur with ADHD. And it's when those types of symptoms are causing interference or difficulties with functioning in different areas of that person's life. So that doesn't require neuropsych assessment in order to diagnose something like ADHD. But definitely, if there are concerns about attention in the context of epilepsy, that's a good thing that a neuropsych assessment can help take a look at.
That's really helpful clarification. Thank you. Our next question is, can the test determine if seizures are caused by non-neurological concerns like anxiety, diabetes, endocrine issues, or even I'll add functional seizures in there as well?
So the testing sometimes will be done when that's a question, but the main way that, at least based on my understanding, that that's detected is, if we do something like we could do long-term EEG monitoring, like in our epilepsy monitoring unit, where someone is hooked up to an EEG for several days, and then they're able to capture when someone has the episode that may or may not be a seizure. Are we actually picking up on electrical changes or brain activity in the brain? And so if they're having the episodes, but there's no seizure activity on the EEG, that really helps inform that diagnosis of a functional or a psychogenic seizure. But no understanding, like there are different risk factors for having that. So sometimes the neuropsychological assessment will help with assessing kind of different emotional factors that might be putting someone at a higher chance of having those types of seizures.
And we have two questions. Do you have any advice on how to find a provider that does the testing, that doesn't have a long wait list or might be in somebody's insurance network?
That's a really hard one, and we are fully aware of the enormous wait lists for many providers. For me here at Boston Children's, and I work with children, the wait list is about 2-3 months. So I think it's shorter than at other places. I know for Dr. Wong, her patient population is kind of bounded by the Westchester Medical Center. The other places Dr. Wong already mentioned are the training clinics. That's the wait list may not be long. There are many providers, however, I don't know about the wait list status on any of them, unfortunately.
Yeah, you can start by doing a search through your insurance to see, if it comes up with neuropsychologists that are within their network, and then try to contact them. Psychologytoday.com is a website that's a helpful website to look up providers as well. And some neuropsychologists might advertise there or have a profile in there. So you can say, in my area, I'm looking for a neuropsychologist. Oftentimes it's therapists or people who are offering psychotherapy, but you might be able to find a neuropsychologist through Psychology Today as well.
Thank you. And just from kind of our experience here at the Epilepsy Foundation, it is definitely difficult, especially in the upstate area, to find somebody who's actively seeing patients or taking on new patients for this. And as you can see, because it's such a long process, a full day of neuropsychologist time. So unfortunately, the wait lists are a little bit long, especially up in this area where we don't have as much specialty care. Okay. Then we have somebody said that their daughter had a brain injury at the age of 6. She had a complete neuropsych exam 2 years after that. It has since been 25 years. Should she get reassessed because she's still having seizures daily?
Absolutely. And Dr. Wong, this would be an adult seeking an evaluation, but from pediatric developmental perspective, certainly recommended to understand what are areas of strengths and challenge at this time, to see whether any kind of guidance and supports might be beneficial to optimize functioning.
Yeah, I agree. I think, so much can change in that amount of time. And, particularly if the individual is experiencing some cognitive difficulties or difficulties with daily functioning, with work, again, the neuropsych assessment can help describe the areas of strengths and weaknesses, and then again, help update and inform recommendations for this point of their life.
Wonderful. That's really helpful. Right, and does the neuropsych exam identify if autism is also present?
It certainly can, and it depends on the provider. Depends on the presentation. Some cluster of symptoms are quite easy to diagnose or rule out that autism is not part of the cognitive picture. For others, it's a gray area where it requires a lot of expertise and knowledge specific to autism. So in my practice, what I do, if that's part of the concern, I will typically inform the family that I might be able to diagnose autism or rule it out, but there is a chance that I might not be able to. I am well versed in autism, but autism is such a complex area, and a lot of individuals spend years perfecting and perfecting their skills and trying to be as excellent as possible. So I may refer for an autism targeted evaluation in that case.
Thank you. And a question specific to Boston Children's. Does the child have to be a current patient like at Westchester Medical to get a neuropsych eval done at Boston?
No, the child doesn't have to be a patient here. However, if there isn't a medical record, it would be important to discuss that with the child's provider neurologist. And some insurance companies may require direct referral that I wouldn't be able to access if I don't have access to the chart. So there may be some additional logistical steps that are necessary, but certainly it doesn't preclude from evaluation here with me if it's a child with epilepsy.
Right. Okay. And do you know of any exchange programs for neuropsychologists from Europe to apply to? So I think we have someone from Bulgaria on the call today joining us.
So exchange programs meaning to get, I guess I'm unsure if it's related to getting training or a certain part of the training process or with work. I'm not specifically sure, but yeah, do you know of any program?
I don't, but I do know an organization called No Neuropsychology that has, I think, or tries to, or had some sort of presentations about neuropsychology elsewhere. And I wonder if maybe there is some sort of information there, or American Academy of Clinical Neuropsychology. These are some organizations that may have some information about that. I know there is certainly a great effort to incorporate European and kind of not American perspectives on neuropsychological assessment.
Yeah, it depends on if someone's trying to come in at the graduate level or come for postdoctoral. So neuropsychologists, part of their training is we do a 2-year postdoctoral fellowship. So I'm not sure if someone would be considering coming for something like that. And there are ones that are more research focused versus clinical focused. So it would definitely depend on what the person's looking for.
Beautiful. Thank you so much. And thank you so much for your time as well today. I know we went a bit over, and as we've already stated, your time is very precious. So I very much appreciate everything that you both provided for us and for our consumers today. If anybody has any other questions, you can send them to me and we can hopefully get them figured out. If not, I will be sending a follow-up email with the slides as well as the link to this presentation. And again, thank you from the bottom of my heart to both of you for presenting today. And I hope everybody else has a great rest of your Wednesday.
Thank you so much. Thank you everyone for coming, and thank you for having us.
Thank you. Absolutely, it was our pleasure.